So what made you become a doctor, Dr. Starobin?
I became a physician. I think I was most influenced by some of the physicians that took care of us in childhood. One was a Dr. Silverman, who was a well-known general practitioner in this area. I remember him making house calls on us. I used to live on the east side on Loxwood Street. And also Dr. Edward Budnitz, who was one of the first cardiologists in this area, when he used to come to make house calls on my mother. And clearly, this was a strong impression, and that's probably why I wanted to be a doctor.
Okay. Where did you attend medical school?
I went to Harvard Medical School, class of 1954.
And what did you end up choosing as your specialty?
Cardiology.
What made you choose cardiology?
I'm not really quite sure. I think part of that was because my mother had a premature heart attack. I'm sure there was an unconscious, for me, influence. The other area of medicine I liked a lot was neurology, and I still do.
So would you like to talk about your medical school experience anymore, your residency, your internship, anything you want to mention from there?
Well, as far as the medical school experience, I found it was, of course, quite interesting. I thought it was a lot of fun, and not really as interesting as college. I think that once you got into medical school, you realized that what you were learning was for a specific purpose, almost like a trade, as compared to university, where you're learning for the sake of learning, not specifically so that you can become a doctor. I did research for several years. I worked in the microbiology department I didn't do the research. I was actually a research assistant to a fellow named Stephen Chapman, who was doing research on Rous sarcoma. That's R-O-U-S. And this particular cancer occurred in chickens, and it was the first cancer, I believe, that was shown to be due to a virus. And that is actually being used as a reference right now as far as the history of cancer in terms of specific agents like viruses causing cancer. They're using the Rous sarcoma model now, and this was, I'm class of 54, 50 years later.
How much did it cost for you to go to medical school?
I really don't know. I had a full scholarship, and I mean, I can tell you, go back to college. College was $400 a year for tuition. In medical school, probably, I think it was probably no more than $1,000 at that time.
So obviously the cost of...
That was a lot of money, though.
Right.
I got my first job when I was 13, and we got 33 cents an hour. So I had saved $2,000 for college, which these days is like nothing, but $2,000 had a lot of buying power in those days, particularly when tuition was only $400.
So the med school class never influenced you in your choices of where or how you practiced, really?
Well, not at all, because I didn't have any student loans. I was fortunate enough to have a scholarship and I did not have to work. In fact, they talked us out of working. I mean, I worked every summer, but they talked us out of working during school because they didn't want us not to get, they wanted us to get the most advantage of the education possible. In fact, I was feeling a little bit poor at one time, and I went to see the dean. I said, I was going to take a job as a part-time telephone operator at night, and they gave me a somewhat larger stipend, so I did not have to work. while I was in medical school, except during the summers. During the summers, I used to work at Memorial Hospital for the pathologist, and at that time, his name was Dr. Sniffen. He was a wonderful fellow who actually taught at the Harvard Medical School as well, and very open-minded and loved to teach. And we were actually trying to work on a test for cancer, and my job was to do the lab work. It was not my initial idea, and it was trying to think of who the name of the researcher was. But in any case, we did do some blood tests to detect cancer, which it really didn't work. As it turned out, it did not work. I think he really gave me these jobs just to keep me employed and interested in medicine, when I was going to medical school. But that was my first exposure to Memorial Hospital, which of course is our partner with UMass. I know what the test was. It was the Huggins, Huggins. The Huggins, he was a very well-known surgeon, developed a blood test for cancer, which it turned out, as I said, did not work out. His son became the director of blood banks at the Mass General, and he was at the MGH when I was a house officer there after medical school.
I just have one more question on the subject of med school costs. How do you feel that the cost of med school today influence the choices of young doctors after they graduate or even during?
It obviously does. They have huge loans. I think the average, I don't know how much it is, but I know it's over 50. It could even be over $100,000 for some of the graduates. The beauty of UMass, obviously, is that if you're a state resident, it's subsidized, largely subsidized. And I think that's phenomenal and very good because it gives them more choice.
So what year did you start practicing?
1960.
Would you describe a typical day when you first started practicing here in Worcester?
Well, a typical day was I had a job at Memorial, a half-time job as director of the cardiac cath lab. This was the first cath lab in the Worcester area. As a matter of fact, I helped to open up the cath lab at St. Vincent at that time, and also consulted at the Springfield Hospital in Springfield, Mass, to help them start their cath lab. So I would come into the hospital in the morning and go to the lab and see what tests had to be done. For example, we needed to develop techniques of measuring the oxygen content of the blood in terms of oxygen saturation. For example, persons with congenital heart disease will have either be, quotes, blue, in which case is a so-called right to left shunt. The blood goes from the right side to the left side abnormally. Or they have left to right shunts where their blood is not deoxygenated. So usually go in the lab, check out, see what's going on there, and then help to develop the surgical techniques of doing heart catheterization. At that time, they were fairly primitive. You had to actually do a surgical procedure to expose a vein to put a tube, a catheter in, whereas now we do everything with needles and wires and no requirement for any extensive surgery. And then I check in with my answering service to see if anybody's looking for me, if there are any consultations there or elsewhere, because I had also went to City Hospital in St. Vincent to do consultations. Later on in the day, usually in the afternoon, I'd go in the office for 3 or 4 hours to see patients, read records, make telephone calls to physicians or to patients or to insurance companies. And on certain days, like on Tuesdays and Wednesdays in the afternoon, we actually did procedures in the X-ray room at Memorial. We didn't have our own laboratory, so we used to share space thanks to the kindliness of the radiologists, such as Dr. Kilroy, Dr. Elliott, Dr. Lingley Sr. of that group. They're very supportive in helping us get started. So they would allow us to share their space certain afternoons so we could study our patients.
How many patients would you have in the hospital at any one time?
In those days, well, I never had, what we would call a large practice. I might have half a dozen at the most at any one time. Spend a lot of my time seeing patients for other physicians like Dr. Sarunian, who was one of our best generalists in the area. I used to see patients for Husick or George McCabe and all the old good guys. And there weren't any, trying to think out loud, if there were any female practitioners at that time. There were very few, except pediatricians like Jane Fitzpatrick. And I used to, since there was no subspecialty of congenital heart disease in those days, and I especially prepared myself at Children's at the Mass General by doing all the pediatric consults at MGH, so I had a fairly large pediatric congenital practice at that time, consultative practice. Another physician that we used to work with closely was Dr. Smith, W.C. Smith, and Dr. Clifford Guptill. Dr. Smith is still alive and well. Dr. Guptill recently passed on.
So how did you keep in touch with your patients outside of your office? How did you communicate with them?
Same way I do now. Telephone, and I write them letters. Very often after you see a patient, there are issues that are raised that it's better to write a letter because then you've documented. The patient gets a piece of writing that they can read and review with somebody else, and I have something for the record, whereas a telephone call largely is not documented, although I still dictate my telephone calls as well, but it's not as good as a letter, in my opinion. It's very labor intensive. Ask your mother about it, she'll tell you.
Did you ever make a house call during the course of
Sure.
practice?
Occasionally, from time to time. Always a lot of fun. I didn't make a habit of making house calls, but I would go if somebody couldn't come or if they're in a nursing home. And sometimes other physicians would call me and say, I've got so-and-so up near Clark or wherever, and they really can't come to see you. It would really help us a lot if you'd go see them at home. So I'd go. Why not?
So how did your typical day change over years of practice up till now?
It really hasn't changed. I just got through teaching electrocardiography to some students and house staff here, and I've always been like the fiddler on the roof, sitting on the roof with feet on both sides, half academic and half practice. I did that from first day of practice. I've had a teaching appointment at the Harvard Medical School at the Mass General since 1954 when I was a resident there, but since practice since 1960. I go there, usually I try to get there twice a month to teach in the cardiac clinic. It gives you a heads up as far as what's going on to academic teaching. I've been affiliated with this medical school before they had a building. We had the tobacco store on the corner of Belmont Street and Lake Ave. And I initially was in charge of third-year medicine, and I used to go to the St. Vincent City and Memorial to check out, make sure our third-year students were learning what they're supposed to be learning, and being treated like student physicians. And that really hasn't changed. The difference now is that I'm full-time over here. I closed my practice. Actually, I donated my practice, and if you want to take a look over here, I can show you 42 years of records right over there. Let me just go over here. This is part of 42 years of records, which are being collated and being finally maintained as records here at the university, so these records will always be available to our patients. And it's quite interesting in reviewing your old records. It's like going through a family snapshot, a family photo album, because I often took, photography is a hobby, I often took pictures of my patients. So I have 20 and 30 year pictures, like lapse of time. Also, you read the old record as you're thinning them out and preparing the record. For example, I'm going to be seeing my patients tomorrow in the cardiovascular center. So today I will pull those records because they haven't been seen here previously. This is not, and as I read the record, I will recall when they had first operation, who was the surgeon, why they had surgery, how the indications, for example, for surgery have changed over the years, and the things that we can do now without surgery, for example, so-called PCI, angioplasty and stenting of vessels, it's only 20 years old. Angioplasty is only 20 years old. Well, my patients go back 42 years. And in fact, some of them longer. Some of them were my patients at the Mass General when I was a resident and a fellow. So that it's the whole history, for me, it's the whole history of modern medicine. When I started out as a cardiac fellow at the MGH, there were no artificial valves. Coronary bypass surgery did not start until the Argentinian Favaloro did this in 1967 at the Cleveland Clinic. Open heart surgery did not start until the early in the mid-50s. I mean, our patients could not be effectively treated with leaky valves or congenital heart disease until the techniques were developed. Now you can have open heart surgery without opening up the chest. Literally, it's done with robots and with little cameras, believe it or not, and without stopping the heart. You can do bypass surgery, and it was done here by Dr. Lancey, except in this case, this is not robotic surgery, but it's not laparoscopic either. But with minimally invasive surgery now, it wasn't even, I mean, bypass surgery, as I said, didn't begin until 1967. So I can go over my old record and say, wow, they had this then, they had this now, and how are we now? Pacemakers were not universally available until 1965. So there's been enormous change in what we're able to do.
Would you care to divert for a second and talk about the academic side of your practice, how that's affected you, and I mean how that's really changed?
Well, as I said, it really has not changed. I've been doing this since the very beginning. It was very interesting. One of my professors and mentors was Dr. Walter Bauer, and he was the Jackson Professor of Medicine, a very well-known rheumatologist at the MGH. And he said, basically, when I left, and he said, you know, he says, you've been, you know, sort of gifted in terms of being able to take care of sick people. And he said, you should start your practice the way you would like to finish it. And it's the same exact advice, because I always mentoring at least two of the fellows, and I helped with Dr. Dahlberg to run the fellows cardiac clinic, where we take fellows who just finished their internal medicine training, and we have to teach them how to be cardiologists and how to practice cardiology. And I give them exactly the same story. When they're ready to go and practice, you know, say goodbye, this and that, but just remember this. Start now like you want to be in 40 years, if you're lucky. So take off time to learn, take time to be with your family. Kids are going to be grown up and out of here before you know it. And you're going to miss their formative years. And you'll be a better doctor if you're able to take time to do all of the above. And if you teach, then you have to learn. You will learn more when you teach than those who you are teaching. So I tell my students and residents who just left here, and it's true. So for me, that hasn't changed. It's always been sort of a half and half. Even though I'm in here full time now, having moved the practice in, about half my time is patient care and half my time is teaching.
Well, that sounds like good advice.
It works.
What do you think it was like for your family to have a physician in the household?
Well, I think it was tough because, you get home for supper and you get that call and you're out of there. I mean, you have to go. I mean, when you're on call, you're on call. For example, most of the really good doctors that I know, like, for example, Leonard Morse, who I think was great, Gunther Spanknebel, who was one of my students years ago. Both have been president of the Mass Medical Society. Both very hard-working, ethical physicians. Take their own call. I mean, they don't sign out except when they're off for the weekend or they're out of town. And so if you get a call, you go. And so it can be very disruptive to the family. And I think that, I don't know how your family was, with mom being a doctor, but I think it'd be very difficult.
Did you take many vacations?
I take regular vacations. I always took off a minimum of 4 weeks a year, usually 2 weeks at a time. Now what I like to do here is I like to take off a week approximately every 3 months so that I get regular time off.
So what were the most typical illnesses that you dealt with early in your career?
What were the most typical?
Right.
Well, for cardiologists, you talk about heart attacks, coronary heart failure, arrhythmias, and so forth. I never practiced any general medicine. I mean, to be a good cardiologist, you have to know medicine because it's all, the heart's just one part of the system. But on the other hand, you can't practice areas where you're not doing it all the time, whether this be, you know, cancer, these days, HIV, or whatever. So that the practice hasn't changed so much as of the types of patients as to the complexity of what we can do for them. The new treatments, the medicines, the beta blockers, the ACE inhibitors, the group of drugs that lower cholesterol like statins, they don't cure anything. They ameliorate. They delay the ending. There are very few true cures in medicine. The cure might be if you were born with a patent ductus, which is a communication between your great artery, the aorta, and the pulmonary artery. If you repair that in childhood or infancy, that's it. It's gone, never comes back. You're perfect. Okay? There are a few congenital defects, like another one would be an atrial septal defect, communication between the upper chambers. If you repair that in infancy or childhood, there probably are no true late sequelae. The other hand, if you have a heart attack, you've had a heart attack, there's an area of damage, you can limit the new infarcts and what they call remodeling, with the heart getting bigger and dilated with the current drug therapy. But you still have a damaged heart. You can live with it, but it's not normal, and it's not going to be normal.
So the illnesses haven't changed as much as the ways you can treat them?
I think that's fair to say. There are newly, HIV was newly recognized, and others, but they've been around for ages.
What was the greatest challenge for you to treat early in your career?
Greatest challenge? I was covering for Dr. Robinson, who was one of the premier early cardiologists in Worcester. He and Dr. Budnitz really were the two, they weren't the only ones, among the two earliest cardiologists. I think Dr. Adams was the first, but I don't want to be misquoted because I could give you the wrong history. Anyway, I remember Robbie went away, and it was my first summer of 1960, and he left me some very sick patients. And my aim was to make sure that they were still going to be around when he got back from vacation. I had one patient I remember with very severe heart failure that worked very hard to keep him alive during that period of time, and we didn't have the drugs that we have today. And so I was very happy to let Dr. Robinson continue their care after he got back. I didn't lose anybody during that month that he was gone.
What was one of the most important breakthroughs in disease treatment during the course of your career?
What, you mean in my cardiology career?
Yeah.
You know, I think that I think development of the heart-lung machine, cardiopulmonary bypass, the ability to repair congenital defects like, for example, tetralogy of Fallot. Mayo Clinic started repairing those in the early 60s. These are blue infants that used to die, and with total repair, they could have normal lives. And other similar congenital defects. And subsequent to that, it was the development of bypass surgery, which unquestionably preserved life and made people functional. Cardiopulmonary, the cardiopulmonary bypass, allowing surgeons to open the chest and to stop the heart because you replace the circulation with the pump, the bypass pump, and be able to bypass the diseased vessels and then warm them up and get going again. I would say that's probably that, and development of good, safe mechanical valves when the vessels get, not the vessels, when the valves get blocked, was also a very important improvement in patient care. As I said, none of that was available when I was in training. None.
How about in disease prevention? Have there been any breakthroughs there?
There have been huge breakthroughs, and I think that gets down to, you know, we sound like we're preachers, but terminating smoking, which causes heart disease, not just cancer, but heart disease. The healthy diet, eliminating the high-fat, high-calorie Big Macs and other similar fast foods, Kentucky Fried. A healthy diet with at least 4 or 5 servings of fruits and vegetables every day, which is better than taking vitamins, because the vitamins, like recent studies have shown, vitamin E, vitamin C, vitamin A, make no difference when you add them. Huge study, just got done in Great Britain, just got completed. 20,000 patients were studied, and part of the study was to do with additional vitamins. No improvement and no detriment. Whereas the use of a drug to lower cholesterol, namely the class of drugs called statins, caused a 20 to 30% reduction in stroke, heart attack, heart failure, all-cause death. Just amazing. And I should say that the development of one of the most important successes since I've been in practice was the development of the randomized trial where persons who are sorted out to be essentially equal in different aspects of the disease, whether it's heart attack, stroke, heart failure, are randomized, allocated blindly to different therapies as compared to a placebo. This is not ethical unless you don't know the answer. So you don't give somebody an ineffective placebo if in fact you know that the therapy is going to make them better. And now we have safety committees that watch what's going on. As soon as there's a divergence, then, and the placebos aren't doing as well. Or, for example, one of the big arrhythmia trials, the so-called CAST trial, cardiac arrhythmia suppression trial, it's the treatment group that was dying 3 times as fast as the placebo group. It was totally contrary to what the hope was for the trial, and so they stopped the trial. So, yeah, but the randomized trial has made an enormous difference in how we treat patients. And instead of treating patients because my professor or your professor said this is the way to go, without this kind of evidence, we found, for example, the latest example is the hormone replacement trials. And for example, for years, women who are postmenopausal were instructed to take estrogen and progesterone. And there are now 3 major trials that show that not only are these drugs not helpful, but they're harmful. Harmful. And this only could come out with a blinded, randomized, prospective trial. So we thought these medicines were correct based on trials like the Harvard physicians, well, not the physicians, the Harvard nurses trial. But it turns out that those were not trials, they're what we call observational studies. And they're based on seeing what happens to a large cohort of nurses over 20 or 30 years. The trouble is the persons who get entered into these trials don't represent the average population. They're usually healthier to start off with, have a higher income to start off with, go to the doctors more often, and more physically active. In this group of persons, it seemed that, for example, HRT was definitely beneficial to reduce stroke and heart attack and osteoporosis. And it turns out that may be helpful for osteoporosis, but at least early on, for the first several years that you take the HRT, there's an increased incidence of stroke and heart attack, and only evens out after 5 years. And it was not understood until there were 3 recent trials done prospectively that what we thought was good was not good. So then you see the news report. Well, how come doctors were prescribing HRT when they should have known it wasn't good? Well, the real truth is that we didn't know. And intuitively and by other types of studies, it seemed to be the right thing to do.
Could you describe the evolution of attitudes towards smoking and cancer throughout the course of your career?
Well, I remember as a student there was, studies being done that show that in laboratory animals they were found that they were exposed to smoke. This was in the 50s, that there were abnormal cells in the lining of the bronchi. The bronchial epithelium was abnormal. And then observational studies were done and they correlated smoking with lung cancer. And that's history. What was the other part of the question?
Just describe our attitudes towards smoking and cancer.
Yeah. I think that as far as cancer is concerned, for a long time, persons with cancer, hid the fact that they had a cancer. A woman would not reveal that she had, say, cervical cancer or whatever. It was sort of like you perhaps were to blame for it in some way, or you're being blamed for it. It's obviously a ridiculous thought, but true. Whereas now, this is much more open and has allowed discussion and has allowed open research.
What were some of the most important drugs that you used in your practice? How have the drugs
You mean now or then?
then and just how they've changed?
Well, a good change, for example, would be the blood pressure pills. When I went in the Air Force as a draftee in 1956, we had no effective drugs for high blood pressure, none. The only thing that we could do is put them on a very low sodium diet, which nobody would take, or they could have a sympathectomy, a so-called Smithwick procedure, which was a very drastic procedure, and if you stood up, you would fall down because the blood pressure would drop, and all kinds of other dysfunctions because of the sympathectomy. And it was only when the diuretics, oral diuretics, came in, which I believe was the late 50s, the early 60s, that we begin to have effective antihypertensive therapy. Now there are literally hundreds of drugs and different classes of drugs. That would be a good example. Another example is, is that we didn't have any effective drugs to treat cholesterol. Now we have, as I said, the statin class of drugs, which are widely advertised. And there's no question that reducing cholesterol and also the effect of these drugs is to stabilize the lining of the arteries, the endothelium, so that it will not rupture. It's made an enormous difference in survivorship. And now we're using the drugs to prevent stroke, heart attack, and peripheral vascular disease. So prevention comes in. Right now, one of the favored interventions is giving your patients fish oils, 2 capsules a day 50% reduction in sudden death if you've had a heart attack, and about 20% reduction in stroke and heart attack just from taking 2 capsules of fish oil a day. And all of this is based on large, randomized, prospective, blinded trials, not because some professor said do this. And the trials are based on, epidemiology, which is looking at the prevalence of diseases in certain populations. Ansel Keys was one of the originals. Also, one of my teachers, Dr. Paul Dudley White, who was Eisenhower's cardiologist, was an early writer. He and Gertler and Keys wrote about preventing heart attacks, and for example, by diet. And they knew the cholesterol was bad at that time. This is 50 years, more than 50 years ago. So, so we've come into this era of prevention, and I think our patients are beginning to understand it. For example, one of my very common referrals, I may be a little bit off the track here, is referring my patients to some of our excellent nutritionists. They're not dietitians. Dietitians, it's a different cadre. Nutritionists teach you to eat healthy. They teach you, for example, cooking lessons, how to use soy and tofu, and why you should have fish and not fried meat, stuff like that. And it's the healthy diets which incorporate the important classes of vitamins that have been clearly shown to be preventive. So we have this whole thing we're going into much stronger prevention.
Did you always have access to the drugs that you wanted to use?
Did I have access? I mean, could I write for them?
Right. Yeah, could you always prescribe them? Did you have any problems with?
Never, if you're thinking it, never been limited by HMOs. They may not want you to use that specific drug, but they'll allow you to use, allow is the wrong word. They'll go along with your advice to use certain classes of drugs.
How about technology? Have you always had access to the new technology in your field? I mean, not necessarily because of HMOs, but...
I've never had a problem.
Is there anything you would like to mention further about medical technology, like breakthroughs in medical technology in your field, or just generally before we move on from that?
I think we covered it earlier with the robotic surgery. As a matter of fact, I drove in from Maine this morning, and I live in Maine but work in Worcester. I live in our old family house with 2 kitties during the week, and one of the things I do is, because it's entertaining, it's only a 2-hour ride, but I listen to medical tapes, so-called Axel College Cardiology. And this morning, one of the topics was robotic surgery. It's a good way to, I mean, it's not a substitute for reading, but it reinforces. For example, I told you about the study with over 20,000 patients. Well, this study was published in the Lancet, British Journal, in April, was first announced in the meetings of November of 2001, American Heart Association. So I just gave a whole session on this to my students and residents, both the fellows last Tuesday and the students and residents in this office, one-on-one on Thursday. And one of the comments was that this is a huge, powerful study that was not advertised. Usually when there's a big study, the drug companies will pick up on it and they advertise on television, newspapers, medical magazines. So it turned out this morning it was actually reviewed in my Axel tape, the same article, the so-called heart protection study that I talked to you about. So this is one of the ways of, and then the reason I like the medical tapes besides being entertaining is that very often they will interview one of the key authors of the study. So you see it from their perspective, not how you read it or you heard somebody else discuss it, but from how the authors who formulated the study, carried it out, analyzed it, and reported it. And that, to me, is very interesting.
So Do you find the tapes a significant part of how you keep up with changes in medicine and education?
It's a reinforcement. It's not primary. Primary is teaching. Primary is going to meetings. I don't go to a lot of meetings outside of town because I'm not a good traveler. But I go down to the Mass General, as I said, usually twice a month to the Cardiac Fellows Clinic, similar to our clinic, but different perspective. And there's very little that's going to fall between the cracks if you're reading actively. I read actively about 6 journals. I try to read 6 journals actively. And these tapes come out and they help you a lot in terms of focusing.
Early on in your career, how did patients without money receive health care?
First of all, there was free care. So, for example, if I had to admission to Memorial in those days with a person who did not have any insurance and didn't have any money, I mean, they got free care from the hospital, and we donated free care. And sorry about that. And after they get out of the hospital, it turns out, patients go in all directions. I have a number of patients who were free patients, say 30 years ago, that subsequently had insurance, but we older docs always took care of them. We did not turf them. I think what's happening now, I'm not sure is exactly what's going on, but we know that, for example, it's illegal. If someone calls your office, it is illegal to ask them if they have insurance or not. Well, you could ask them, what is your insurance, I suppose, but you cannot exclude them by law, at least my understanding of the law. But I think that many physicians have figured out a way to get around that.
Over the years, how do you think Worcester is compared to other places in terms of providing care for the underserved?
My own experience, I think it's good. I mean, for example, when I had my clinics both at Memorial, also at City, and also at St. Vincent, we had free clinics in those days. And we have UMass has a large number of persons who don't have insurance, don't have money, they get free care. In a way, here they're being subsidized by the group practice, because if I see free patients, the group practice that, overall runs the practice gets nothing out of it.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Well, they thought that the government would be in charge and wouldn't let us practice the way we know how. It hasn't worked out that way, as you know. Although I think that I think as a society that we really failed the public in not providing equal access.
What were your feelings on, or before that actually?
Medicare, Blue Shield?
Yeah. Well, actually, could you tell me first, were physicians involved politically on the topic of socialized medicine? Were a lot of physicians?
Well, I think the AMA was against it, very much against it. And I'm one of these independent cusses that does not belong to the AMA. I think that politically they're way over to the right. I personally have always been an independent voter, and although my family thinks I'm Republican, I am not. And in fact, my big kids thought they thought I voted for Nixon. I said no, and I happened to be a student of President Nixon's activities, and if the guy weren't so warped, he would have been a great president. He was a brilliant guy. And do you know why he didn't go to Harvard Law School? Because he couldn't afford to go that far east, actually. Pretty sure he went to Duke. Getting back to...
yeah, now tell me your feelings on Medicare and Medicaid.
Well, no, I think that, I've always participated in both. I just don't think we have enough of it. I think that persons who, You know, I mean, you think about the underserved population, the kids who don't get pediatric care, don't get their shots, kids who lose all their teeth because as a group the dentists have not come forth and given free care. As a group, I'm not attacking dentists and my friends and associates, but as a group the dental societies have not supported free dental care. And lack of adequate care at every level, kids, young adults, it's a travesty in the richest country in the world. It's actually ridiculous. And I think the Canadian model is much better. There's no model that's perfect. Great Britain, you know, socialized system, they just poured a ton of money to update the system. You know, you have to wait a year to get your gallbladder out unless you're acutely ill, maybe 6 months to have a bypass operation if you weren't suffering. But at least there's equity. You know, the Brits after World War II, they're very they're willing to wait, so-called queue up, and take their turn, and people would not get in front of the queue. They do have a secondary private insurance market for those who don't want to wait and those who can afford it. You could argue that's unequal, but here at least everybody can get some good care in Great Britain. And incidentally, with all the procedures that we do in this country, our outcomes are no better than, for example, Canada. No better. So it tells you a lot. In Canada, they obviously have problems. The provinces, they run out of money. Some patients, like women who are pregnant, will cross over to the states adjoining Canada to have their babies because they have certain needs that they would like to have addressed. But overall, the quality of care is at least as good as ours in Canada, and everybody's entitled to care, to my knowledge.
So are you saying, or did you say that the government's overall involvement in healthcare has been has had a negative impact on the public's access to care? Is that what you're...
I don't think it's been negative at all, but you know, again, I'm a half full instead of half empty type of person. I mean, I think Medicare has been terrific. If you could extend Medicare to the whole population, it would be terrific. You know, Medicare patients come in, they get their medicines as a group. Well, it depends what adjunctive policies they have, but they certainly can get their medical care. Medicaid patients in some states like Massachusetts, they do well. They get their prescriptions, they get everything they need. But Medicaid is dependent on the states. So the very poor states, of course Massachusetts is becoming very poor now, but the very poor states, for example, they'll only spend the amount of money that they're required to by law to take care of their patients. So I don't want to mention the states because it would be inappropriate. But my experience with Medicaid in this state, I mean, they may argue with us that they don't want a certain brand name drug, but there's no evidence that generics as a group, not specifically, are not as good as brand names at nth the cost. Certain drugs cannot be substituted, and Medicaid will usually buy that, although lately they've become very tough about that as well.
Would you care to talk about the effects of managed care and HMOs on physicians like yourself?
Well, as I said, you know, I never felt badly impacted, but as a quote subspecialist, we really it's different than being an internist or a generalist. A general practitioner has to carry a certain volume of patients with some of the HMOs to make a living, and the reimbursement is not sufficient for them to give ideal care. So I think if you talk to a generalist, you might get a different answer. I personally have had very few limitations. You know, if we made the case properly, I've never had anyone turned down for anything, literally. If I want to send someone down to Mass General or the Brigham or Children's for things that can't be done in a caregiver's point of view as well as is available in Worcester because of lack of experience, have never been turned down. But I say that's a very different issue as compared to a generalist who, where the reimbursement is so low that they have to see a high volume of patients just to pay their office overhead, never mind to make a living. How are we doing for time?
We have about 10 minutes left.
Okay.
And so, well, could you tell me how doctors' salaries have changed over the course of your practice?
They've gone down. They really have. I mean, I can only speak for myself, but of course, I always had a half-time practice and half-time, position. I was director of the cath lab at Memorial for 25 years. Went over to St. Vincent as chief of cardiology for 3 years. Ran their cath lab for a 4th year. Came over here in '89 on a half practice, half here. And the academic salaries, particularly at UMass, are probably in the 10th percentile for the whole country. They're low. I mean, it's not that they're not adequate, but they're low compared to private practice. So, if anything, my income has gone down steadily over the years.
How has malpractice insurance, as well as its impact on doctors' practices, changed over the years?
Well, malpractice insurance was very high, say 10, 12 years ago. Then there was some attempt at reform, and it went down, and now it's going back up again. And there's some states where, for example, pretty sure it was Nevada, where they closed emergency rooms. I mean, it cost more for the malpractice insurance than they could generate. So doctors quit practicing. Same thing for obstetrics and gynecology. There's some very high-risk states right now, like Florida, Pennsylvania, where you may have to drive 40 miles to get to an OB or an emergency department. And up to now, the U.S. government has failed to reform, and that I know it has to do with the insurance lobby. The insurance lobby. It's not, everyone wants to blame the plaintiff attorneys. They don't sue people. Patients sue, okay? Plaintiff attorneys are highly specialized, and they're able to successfully carry the case if there's anything there. On the other hand, like in Massachusetts, if you go to trial, there's approximately an 85 to 90% probability that the defending doctor is going to win. But that takes time and is very expensive. And at the end as well is the plaintiff who's been hurt gets nothing. They end up with nothing. If they lose the case, there's nothing. So, we think similar to auto insurance, that there has to be some kind of system where the injured party will be compensated in some way. But the other side of that are these juries that are giving out $20 million settlements, and awards, not settlements. And the insurance companies can't afford it, and the docs go belly up, and they quit. They don't, being sued, I've been there, I know what it's about, is very painful. It's painful, it's a personal threat to you, and even if you're insured, you're going to get dragged through the process for 6 or 7 years, and the person suing you or their family has to wait that long to get any kind of compensation for the loss. And it's a total no-win situation. I think it's driving a lot of doctors to quit early, not my case obviously, and persons to go into practices where there's less litigation. For example, I talk to my students and my residents and want to know what they're going to go into, and we do talk about some of these issues. And for example, they want to avoid areas that are highly litigious, such as anesthesia, emergency department, neurosurgery, orthopedics. They'd rather do something like ophthalmology, where the risk of being sued is much lower.
Right.
It's not a good thing, but you have to, you know, until the government wants to change this, and I don't think it's going to happen until there becomes a, you know, and there are fewer students, fewer persons wanting to go into medicine for the same reason. Why bother doing this? You might as well go get your MBA or go to law school.
So how did you end up learning the business of medicine?
I learned it from asking other physicians, the senior physicians that I work with, and by trial and error.
Okay. Do you think that's something that could be covered a little more in medical school? Or
Absolutely should be, right. Part of our regular conferences that we give for our cardiac fellows and our students are bringing up billing issues. For example, Dr. Dahlberg in the group here is very, very knowledgeable about HCFA's rules, and so we have regular sessions about billing honestly and maximally, for example, so that you're doing it, your documentation will support the level of billing. The other thing that I do is that I get involved with is what we call risk management, and that is making the students and the house staff and the fellows aware of the risks of practice and how to avoid it. Like, how do you keep a good record? How do you not alter a record once you've written it? How do you get, for example, informed consent? All these, we bring this up, and I have invited speakers. And for example, I had the director of the Board of Registration in Medicine here last year. This year, among other talks, I had an attorney who defends physicians whose licenses are threatened by the Board of Registration in Medicine, what you should do, what you should not do if you don't want the board to come after you. Because medicine is, practice of medicine is a privilege, and you can lose it quite easily. We call that reality training.
Okay. We have about 5 minutes left. Could you tell me what some changes are that you've seen in the demographics of the Worcester community?
Well, I think we have a, you mean who lives here, who do we take care of?
Yeah, how have your patients changed over the years?
Yeah, well, I mean, of course, university practice is different than private practice in a sense. Private practice is almost always a referral practice. In many cases, that's persons who've lived in the Worcester area for a long time, who have established physician relationships. Here, and I think it reflects the demographics of Worcester, we're seeing much larger Asian population, particularly Vietnamese, and of course Hispanic population. And they're lovely people to deal with. I enjoy them a lot. It's sort of they're a throwback to my parents. They came over in the 20s. These are the new immigrants.
So, how has Worcester been different from other places that you've practiced?
So I've only practiced here. I've taught at Boston. I think the thing about Worcester is it's still a pretty stable and close-knit community, so that I can end up taking care of a grandfather or a great-grandfather, a grandmother, a son, a grandchild. I can 4 generations in one family because they've all stayed in the area. That's really a lot of fun because they know you, you know them, and you get, the bonding occurs very quickly and early. It's very easy. It's a lot of fun.
Do you still find that doctor-patient relationships are the same as early in your career? I mean, are you still close with your patients?
For that matter, nothing's changed. I moved practice here. You saw all those boxes in April, and to date, I have only one patient who chose not to come here because, and it is difficult to, the whole system is, it's not like my old office, or 2 offices, one on Lincoln Street, one on Oak Ave. You drive into the parking lot, you don't pay, drive up to the door, you get out, you're in the doctor's office. To come here, it's a real project. It is difficult for people, particularly who don't live in the exact Worcester environment. So it's a challenge to get there. In fact, I just received a letter, very nice gentleman, who was, his blood pressure was very high when he came in the office because he was almost late. Finally, he went to the Memorial campus first, then he came to this campus, and he left his wallet on the front seat when he gave his car to valet. And valet came in, and his pressure was quite high. Immediately came down, so he wrote me a very nice letter saying he found his wallet, he liked coming, he'll be back in another year, and his blood pressure won't be so high. So there is a difference. The only other thing I have to say is I tell my fellows this: I'm really in a way sorry that I can't start all over, because there's so much stuff going on. It's so interesting. Medicine is so very interesting in so many ways now because of all the research, the innovations, the techniques, the technology. Yeah. And I would love to start all over. On the other hand, my teachers, I was very lucky when I was learning. My professors, Paul White, took care of President Eisenhower, the Wolff-Parkinson-White syndrome. David Littman, who invented the stethoscope, who was a teacher. You go down the list. Walter Bauer. I mean, they were outstanding clinicians and leaders, and they weren't dependent on high tech to get things done. They had to use their cognitive and personal abilities to make things happen. And I think with high-tech medicine, this is very definitely being lost.
Well, in the last 40 seconds we have, could you just tell me what advice you have for younger doctors, Dr. Starobin?
My advice is be yourself, be a lifelong learner, and you could be a learner if you're a teacher, and try to be nice to people, and be professional. Professional means that if you're in a bad mood that day for whatever reason, you don't transmit that to your patient.